when you step into the world of trauma surgery, there's this expectation of just, well, mechanical precision.
Right. Absolutely.
You
Right.
know the environment. You live it.
Yeah.
You're out there managing the chaotic reality of a level 1 trauma center on a daily basis.
Yeah, it's your baseline.
Exactly.
Yeah.
But what happens when the sheer mathematics of arriving bodies completely, outstrips the physical and organizational physics of your hospital?
That's the nightmare scenario.
It really is.
Yeah.
What happens when the standard advanced trauma life support protocols,
Mhm.
I mean, the ATLS algorithms that are literally hardwired into your muscle memory become the exact things that cause your system to fail?
Well, that is the terrifying threshold where individual medicine ends, right? And population survival begins.
Wow, yeah.
The medical paradigm, it doesn't just bend at that point, it completely shatters.
Right.
Because of the foundational infrastructure, your imaging, your blood bank, your operating rooms, it all becomes a series of fatal bottlenecks.
So you have to fundamentally deconstruct how a level 1 center operates.
Exactly, and rebuild it for a scenario where resources are strictly finite, but the influx of patients is practically infinite.
Welcome to the Deep Dive. Today, we are speaking directly to you, the United States-trained trauma and surgical critical care surgeon.
Glad to be here.
Our mission today is to unpack the exact inflection points where your standard protocols and, frankly, your individual clinical autonomy must pivot to a system-wide, utilitarian model of survival.
Which is a massive mental shift.
A huge one.
Yeah.
And we're drawing from a foundational text for this. It's the chapter, Mass Casualty Events, the Role of Hospitals and Trauma Systems, by Dr. William Schechter and Dr. Asher Hirschberg.
And the transition they outline in this text is just profound.
Yeah.
Yeah, because the mindset required to run a trauma bay on a normal Tuesday is entirely adversarial to the mindset required when your facility's surge capacity is breached.
Right.
So today is really about the mechanics of that shift. We aren't just talking about, what protocols to pull up. We're talking about the why and the how of scaling trauma systems under catastrophic pressure.
Okay, let's unpack this.
Yeah.
Because one of the first critical realities Schechter and Hirschberg identify is a massive gap in surgical education.
Huge gap.
I mean, your residency and fellowship trained you to execute an emergent resuscitative thoracotomy flawlessly, right?
Yeah,
They
right.
taught you how to run a massive transfusion protocol. But formal curriculums rarely cover the actual logistics of a mass casualty event, or MCE.
They really don't.
They don't teach you how to physically and psychologically manage 100 arriving casualties while the city's infrastructure collapses outside your doors.
And the statistics say you might be the one designated as the surgeon in charge during the next major event.
Exactly. You might be the one who has to put down the scalpel and pick up the clipboard.
And to prepare for that role, we have to look at the exact parameters of the environment.
Right.
The terminology we use dictates the operational response. We aren't just arguing semantics here.
We're defining the operational boundaries of the hospital.
Exactly. So the text categorizes these events into 3 distinct phases. You have the multiple casualty incident, the mass casualty event, and the disaster.
And the boundaries between those phases are defined entirely by your system's surge capacity.
Right. So let's look at the first phase, multiple casualty incident, or MCI.
This is essentially just a terrible shift, right?
Yeah, exactly. A terrible shift, but one your system can absorb.
Right.
An MCI is a sudden, large influx of casualties, but your facility mobilizes internal resources and continues to deliver a normal standard of care.
So your baseline metrics don't degrade.
No, they don't. If a patient needs a CT pan scan, they get it. If they need an immediate laparotomy, the OR is ready.
Because if we look at the mechanics of an MCI, it means your queuing theory still holds up.
Precisely. The number of arriving casualties is less than your available trauma bays and less than your immediate OR availability.
So the system bends. You might call in a backup team, or maybe you delay an elective case.
Right. But the patient with a, say, grade 4V splenic laceration still travels the optimal gold standard pathway.
But then we hit the critical threshold, which is the mass casualty event, the MCE.
This is where things get scary.
Yeah. An MCE occurs when the arrival rate of severe casualties exceeds the actual surge capacity of the facility.
That is the exact moment the physics of your hospital break down.
And the text is incredibly stark here. It says an MCE implies a definitive failure to provide optimal, timely trauma care to all severely injured patients.
And that word failure, I mean, that's a physiological and psychological shock to a trauma attending.
Oh, absolutely.
Your entire career is built on the refusal to fail the patient right in front of you.
Right.
But in an MCE, acknowledging that failure is literally the only way to pivot to aggressive triage.
Because you can no longer provide optimal care to everyone.
Exactly. You must ruthlessly prioritize patients with major injuries who have the greatest physiological chance of survival.
You can't expend finite resources on minor injuries.
No. And crucially, you cannot expend them on patients with non-survivable physiology.
And then there's a terrifying threshold past the MCE, right?
Yeah.
A total disaster scenario.
Right. Think of the 9/11 attacks, the 2004 tsunami, or Hurricane Katrina.
In a disaster, the medical paradigm just ceases to exist.
Completely. Because the foundational societal infrastructure, the power, the EMS, security, roads, it's all gone.
So the ability to mount an organized medical response without massive delayed outside assistance is just impossible.
Right. The initial priorities aren't even surgical at that point. They're basic human survival, security, shelter, water.
So the hinge point between an MCI and an MCE is this concept of surge capacity.
Yes,
And the authors provide a deeply calculated metric for this, right?
they do. A typical emergency department can process one severely injured patient per hour per 100 hospital beds during normal business hours.
Wow.
That is the mathematical limit of modern trauma logistics.
Wait, let me push back on this for a second. So if I'm at a 500-bed hospital on a Tuesday afternoon, my threshold for an MCE is 5 severe trauma patients arriving at once.
Basically, yes.
That feels incredibly low for a major U.S. Level 1 trauma center. Like, my intuition immediately rebels against that number.
Of course it does.
If I get a pager alert for a bad multi-vehicle pileup with 5 patients, I'm not declaring a mass casualty event. I'm just getting another attending down to the bay.
What's fascinating here is when you actually look at the systemic friction points. Processing a severely injured patient is not just about placing them on a gurney and starting 2 large bore IDs.
Right.
It is the immediate synchronous monopolization of highly complex pathways.
Like the CT scanner.
Exactly. It's the CT scanner turnaround time. And not just the scan itself, but clearing the table, the software reset, the whole process.
And the massive transfusion protocol.
Yes. If you have 5 actively exsanguinating patients, you're asking the blood bank to simultaneously prepare and deliver 5 separate coolers of uncross-matched blood.
The pneumatic tube system physically cannot handle that volume.
Right. You are suddenly depleting your entire thawed plasma inventory in 20 minutes.
Wow, yeah.
And then look at the OR footprint. 5 immediate laparotomies mean you are instantaneously pulling 5 anesthesia teams, 5 circulating nurses, 5 scrub techs, and 5 trauma attendings.
So the bottleneck isn't the physical space in the trauma bay.
No, not at all. It's the downstream logistical choke points. When those 5 patients arrive at a 500-bed hospital, you are redlining the entire facility's physical and operational limits.
And that metric, 1 per hour per 100 beds, that's for optimal Tuesday afternoon staffing?
Oh, absolutely. The surge capacity just plummets on nights and weekends.
Right. At 2 a.m. on a Sunday, the CT tech is probably covering inpatient scans up on the neurology floor.
Exactly. The blood bank has a skeleton crew.
The backup general surgeon is asleep at home, 20 minutes away.
So the moment you exceed that specific threshold, rapid system-wide activation is literally the only mechanism that prevents the MCI from deteriorating into a catastrophic MCE.
So to operationalize this for you, the listener, let's look at how an MCE specifically accelerates physiological decline.
Right. Take a patient with penetrating abdominal trauma and active intra-abdominal hemorrhage.
In an MCI, they bypass the noise. The FAST exam is positive. The pressure is soft. They're resuscitated en route to the OR, and you have proximal control in 15 minutes.
But in an MCE, the system is fundamentally overwhelmed.
Yeah.
The surgeon in charge visually identifies the shock state at the door, but because the surge capacity is breached, the CT scanner is backlogged with 3 other unstable patients.
And all the immediately available ORs are full of casualties from the first wave.
Exactly. So that life-saving laparotomy is delayed by an hour, maybe 2.
And we know exactly what happens during that delay.
The lethal triad.
Yep, hypothermia, acidosis, and coagulopathy. And it doesn't wait for OR availability.
No, it doesn't. The MCE environment accelerates the triad because the patient might be waiting in an improvised bay without a fluid warmer.
Or receiving crystalloid instead of immediate 1-to-1-to-1 blood products because the MTP is rationing.
Exactly. By the time that patient reaches the OR, which, by the way, might be a PACU bay hastily converted for surgery,
Right.
operated on by a subspecialist who hasn't done a trauma laparotomy in a decade, the coagulopathy is irreversible.
The delay dictates the non-survivability.
Yes.
And if we push that same patient into the disaster scenario, the outcome is entirely predetermined by the environment.
Because the infrastructure collapse means EMS cannot reach them.
They exsanguinate on the street, or they're carried by civilians to a hospital that's lost generator power and can't even sterilize instruments.
So we understand the fragility of the system. The next critical phase is understanding the geometry of the influx.
When the sirens start, how do you separate the critical signals from the overwhelming noise?
Well, the authors present a statistical reality that is both a logistical nightmare and honestly a crucial anchor for the surgeon in charge.
The universal injury severity distribution.
Yes. Regardless of the mechanism of the event, only about 10% to 15% of the survivors presenting to the hospital will actually be severely wounded.
Okay.
And of that 10% to 15%, roughly one-third will have immediate life-threatening injuries requiring your advanced surgical skills.
So the overwhelming majority will sustain relatively minor injuries.
Exactly. If we look at the data from the London subway bombings in July 2005, it perfectly illustrates this distribution.
Okay, let's look at that.
The Royal London Hospital received 194 casualties within a 3-hour window.
I mean, logistically, 194 patients hitting an ED sounds insurmountable.
It does, but the distribution holds. Only 27 of those patients, about 14%, were severely injured.
Okay.
And of those 27, only 8 casualties, just 4% of the total, sustained immediate life-threatening injuries.
Wait, 8 patients out of nearly 200 terrified, bleeding, covered in debris casualties hitting the doors.
Yes, your entire mission is finding those 8 patients.
Because the sheer volume of the walking wounded creates this massive physical and psychological barricade between your trauma team and that critical 4%.
Exactly. The death toll at the scene is heavily dependent on the mechanism, like structural collapses like the Oklahoma City bombing have massive immediate mortality.
Right.
But for the survivors reaching your dock, this 10% to 15% severity distribution is almost always the rule.
And filtering out that 4% begins long before they even hit your ambulance bay.
Right. It begins with the pre-hospital triage algorithms executed by the incident commander out at the scene.
Because the receiving hospital is really just a single node in a massive response network.
Exactly. Out in the field, amid the absolute chaos, responders are utilizing the SALT triage algorithm.
SALT, meaning sort, assess, life-saving interventions, treatment, and transport.
Right. And to be clear, this isn't ATLS. This isn't a careful primary survey.
No, this is hyper-efficient, split-second physiological categorization.
The mechanics of the SALT global sort are fascinating. Responders use auditory and visual commands to separate the masses.
They literally use loudspeakers, right?
Yes, over loudspeakers, they instruct anyone who can hear them to walk to a designated area.
So immediately, you've isolated the walking wounded, the noise.
Exactly. Then they ask those who cannot walk to wave an arm.
Okay, so you've identified purposeful movement and command following.
Right. And the casualties who remain entirely still are the ones assessed first.
And that assessment is stripped down to the absolute bone.
They aren't placing stethoscopes to listen for equal breath sounds.
No, they're looking for massive compressible hemorrhage. They're checking for airway patency.
And the life-saving interventions phase is limited to actions that take seconds.
Like applying a tourniquet.
Or repositioning an airway, darting a chest for a tension pneumothorax, or maybe using auto-injector antidotes.
If we connect this to real-world metropolitan events, the 2013 Boston Marathon bombings proved the profound efficacy of this immediate intervention phase.
Absolutely. The widespread use of improvised extremity tourniquets by bystanders and first responders at the point of injury directly prevented exsanguination.
They executed the L in SALT flawlessly.
They did, keeping those patients with traumatic amputations alive long enough to reach the transport phase.
Now, for the transport phase, the algorithm asks basic binary questions.
Right. Does the patient have a peripheral pulse?
Are they free of severe respiratory distress? Do they obey commands?
And if they fail these checks but have a chance of survival with immediate care, they are tagged immediate and loaded into the first available ambulances.
But this introduces a massive systemic vulnerability.
It really does.
Because ideally, the EMS incident commander uses a load balancing algorithm distributing those immediate patients evenly across every level 1 and level 2 trauma center in the metropolitan radius.
They're supposed to act as a distribution sponge, soaking up the impact so no single facility's surge capacity is breached.
But the reality of urban geography means that the closest hospital almost always gets the first, most massive wave.
Because bystanders aren't waiting for EMS. They will throw casualties into the back of pickup trucks or Ubers and drive them to the nearest glowing red emergency sign.
Right, so the EMS buffer is entirely bypassed.
Which brings us to minute 0 in your emergency department.
The alert has been sounded. The sirens are approaching. How does the U.S. trauma surgeon's role fundamentally alter in that first hour?
Well, the very first action has nothing to do with surgical intervention. It's about creating physical and operational space.
Because when the notification hits, you usually have a brief time lag before the first casualties arrive.
That is the golden window.
The immediate mandate is the rapid, aggressive evacuation of the emergency department.
You discharge every single patient who can stand.
You transfer every remaining ED patient to inpatient floors, regardless of whether the receiving nurse is ready.
Because the text is absolute on this point, attempting to absorb an MCI into a full ED guarantees systemic failure.
Right, you're instantly converting waiting areas into walking wounded holding zones.
You're expanding resuscitation bays into the hallways.
You're halting all elective cases in the OR.
And aggressively extubating or transferring suitable ICU patients to step-down units just to clear the traumatological core.
And standing at the epicenter of this massive spatial reorganization is the surgeon in charge.
This is where your identity as a trauma surgeon undergoes a pretty violent shift.
Here's where it gets really interesting, because you are used to being the solo artist, right? The mechanic fixing the engine.
You see a problem, you fix it.
Exactly. But as the surgeon in charge, you suddenly become the pressure release valve for the entire hospital.
Your job is to decide which pipes get shut off so the whole system doesn't burst.
And to manage that pressure, the text details a specific triage cascade.
Right. You do not wait for patients to enter the ED.
No, you deploy a highly experienced triage officer, ideally an attending surgeon or a senior emergency physician, directly to the ambulance dock.
Their sole responsibility is to act as a physical barrier.
They steer the critical casualties into the resuscitation bays and physically direct the walking wounded to alternate locations far away from the core.
And it is entirely reliant on what the authors call the eyeball impression.
Because there is no time to hook up a monitor.
No time to cycle a blood pressure cuff. You are assessing skin pallor, capillary refill, obvious hemorrhage, and work of breathing in 3 seconds.
You look at a patient being pulled from the back of a police cruiser and instantly decide resuscitation bay or delayed care.
And this is exactly where the loss of clinical autonomy creates immense friction.
Oh, yeah. In daily practice, a trauma team leader does not ask permission to take an unstable patient to the CT scanner or the OR.
No, you own that patient.
But in an MCE, multiple trauma teams are working simultaneously in adjacent bays, and they are all competing for the same finite resources.
Right, so picture yourself as the surgeon in charge. You're standing at the head of the bays with a clipboard. You have exactly one OR available because the backup teams haven't arrived yet.
Right.
Your colleague, an excellent trauma attending, is bagging a patient with a gunshot wound to the abdomen. Pressure is in the 70s. They look at you and say, "I'm going to the OR."
But you just got radioed from the doc triage officer that 3 patients with traumatic amputations and untourniqueted junctional bleeding are coming through the doors right now.
So you have to look your colleague in the eye and say, "No, you cannot have the room. Resuscitate with blood in the bay and wait."
I mean, that interaction violates every instinct of the trauma surgeon.
It really does. But the surgeon in charge must maintain the perspective of the entire population.
You cannot allow one team leader to unilaterally drain the massive transfusion protocol or monopolize the single available OR without weighing that patient's acuity against the casualties arriving in the next 5 minutes.
And to survive this bottleneck, the entire clinical approach shifts to what is known as phase 1 care.
Right. Phase 1 care strips modern medicine down to its most primitive mechanical essentials.
The CT scanner, which we rely on for almost everything in modern trauma, it becomes a lethal trap.
You have to defer all rule-out imaging. If you wait 45 minutes for a pan scan, the 3 patients stacked behind them will exsanguinate.
The text provides highly specific mechanical rules for phase 1. Suspected long bone fracture, no x-rays.
You apply a traction splint, administer analgesia, and immediately move them out of the bay.
And the most difficult paradigm shift involves abdominal trauma.
Yeah.
If you have a hemodynamically stable patient with peritonitis, a patient with a rigid abdomen from a hollow viscous injury, they do not go to the OR.
Sitting on a surgical abdomen goes against everything we are taught.
Yes, and that is exactly why the mental preparation for an MCE is so vital. You give that stable peritonitis patient broad-spectrum antibiotics, IV fluids, and analgesia, and you place them in a delayed holding area.
Because you must conserve that operating room for the actively exsanguinating patient.
You are trading a higher risk of sepsis later for the guarantee of preserving a life right now.
You also enforce a strictly one-way flow of traffic out of the ED.
Right. Once a patient is stabilized and moved to the OR, the ICU, or a designated ward, they cannot return to the ED for any reason.
If a patient on the floor decompensates, the rapid response team manages them there.
Because the ED must remain an open intake pipeline. The moment traffic flows backward, the pipeline clogs and the ambulance dock backs up into the street.
So we've mapped out the mechanics of the emergency department. But what happens when the geographical cluster of the incident is too dense?
Like when the first wave isn't 20 patients, but 100.
Exactly. When the surge capacity is unequivocally breached across the entire facility, we have to shift our focus from the ED to the hospital-wide response.
When the surge capacity is breached, the standard of care inevitably drops. The text states that under these catastrophic conditions, the overarching goal of the hospital is to fail well.
Failing well. That means shifting from a medical model of consensus and consultation to a rigid incident command model.
Yes. You deploy the Hospital Emergency Incident Command System, or HEICS.
This is a military-style hierarchical structure designed to eliminate the inefficient communication matrices we use daily.
In HEICS, span of control is everything. Every individual supervises a maximum of 5 people and reports to exactly one person.
So you don't have 3 different departments calling the blood bank.
No, you have one logistics officer managing all blood procurement.
And the administrative hospital incident commander establishes a command center far removed from the clinical chaos.
Their entire function is to put the hospital on a war footing, managing security perimeters, physical plant operations, media relations, so the clinical teams can focus entirely on physiology.
And while the administration runs the hospital infrastructure, the surgeon in charge relies on staged triage to protect the facility's most vital assets.
The traumatological core.
Right.
Yeah.
This core consists of the resuscitation bays, the operating rooms, and the ICUs.
Because if the core is overrun by walking wounded or panicking civilians, the hospital's ability to save lives just terminates.
You layer your defenses. You have primary triage at the ambulance dock deflecting the non-critical.
You have secondary triage inside the ED doors making the split-second decisions for the base.
And crucially, the text emphasizes tertiary triage.
Right. The surgeon in charge places experienced clinicians, often senior anesthesiologists or surgical attendings, directly at the physical entrances to the ORs and ICUs.
They act as gatekeepers.
They ensure that absolutely no patient enters an OR without the explicit authorization of the command structure.
Which forces us to confront the darkest, most agonizing reality of the MCE protocol.
Yeah.
To fail well, to protect the salvageable, you must utilize expectant care.
From an operational standpoint, executing expectant care means the surgeon in charge actively, consciously decides to deny life-saving resources to a living, breathing trauma patient.
Because their physiological baseline requires too much investment for too little yield.
Right. Think about a routine shift. If a 25-year-old with a stab wound to the chest loses vital signs in the trauma bay, you are performing an emergent resuscitative thoracotomy.
Absolutely. You crack the chest, you cross-clamp the aorta, you internally defibrillate. It is a massive, highly coordinated effort that consumes an attending, a fellow, 2 residents anesthesia, 4 nurses, and 10 units of uncross-matched blood.
Yes, and the survival rate for an ED thoracotomy is, what, in the low single digits?
Yeah, very low.
During an MCE, while you consume an entire resuscitation team and a massive fraction of your blood supply for a 2% chance of survival, 3 highly salvageable patients, perhaps with tension pneumothoraces or compressible extremity hemorrhage, are dying unattended in the hallway.
And the authors are uncompromising on this. An ED thoracotomy during an MCE is an unjustified, catastrophic waste of resources.
The physiological thresholds for unsalvageability just completely change.
A patient who is actively coding from blunt trauma is immediately moved to expectant care.
A patient with massive, devastating traumatic brain injury and blown pupils is moved to expectant care.
The surgeon in charge must shoulder the profound moral injury of declaring those patients unsalvageable.
You are looking at a patient you know you would try to save on any other day, and you are ordering palliative sedation instead.
It is the ultimate brutal execution of utilitarian calculus.
And the psychological toll of this is exactly why the text insists the surgeon in charge must be the most experienced, resilient clinician available.
It's a weight that stays with you long after the shift ends.
It really is.
And that brings us to a critical pivot in the text. Most of these events, a mass shooting, a bridge collapse, a train derailment, they're acute.
Right. The massive influx happens over a few brutal hours, the patients are processed, and within 24 to 48 hours, the hospital is stabilizing.
But what happens when the mass casualty event simply does not stop?
We enter the realm of the ongoing MCE.
The logistics of a sprint are entirely useless in a marathon.
The authors actually draw heavily from their own operational experiences here, citing the month-long 2006 Lebanon War.
Right.
During that conflict, hospitals in northern Israel were forced to operate in a continuous, high-alert emergency configuration under the constant threat of intermittent missile attacks.
So you aren't just dealing with a single wave of patients. You're dealing with unpredictable, recurring waves while your staff is operating under the psychological terror that their own facility might be struck.
And if we look at a more recent global paradigm of the ongoing MCE, the text points directly to the COVID-19 pandemic in major epicenters like New York City.
The hardest-hit hospitals spent months deployed in an emergency posture.
They canceled all elective surgeries, converted every square inch of space into clinical areas, and operated with a fundamentally altered standard of care.
And the COVID-19 paradigm forces us to evaluate the MCE framework from a completely different mechanical angle.
Right, because in a kinetic trauma MCE, like a bombing, the critical choke points are the operating rooms and the blood bank.
But in a biological MCE, the kinetic trauma is absent.
The bottleneck shifts entirely to intensive care capacity and mechanical ventilation.
And the physical structural adaptations required were staggering. The text notes how institutions like Columbia University Hospital had to convert sterile, empty operating rooms into makeshift, multi-bed ICU wards.
The sheer volume of patients suffering from catastrophic respiratory failure completely obliterated standard ICU surge capacity.
Which highlights a vital concept regarding system buffers. We discussed earlier how a highly functional EMS system acts as a sponge for a trauma MCE, distributing patients across the city.
Right, to protect individual hospital surge capacity. But for a biological epidemic, EMS cannot act as the buffer.
The text draws this brilliant parallel. The equivalent buffer for an epidemic is a robust, aggressive public health response.
It's the exact same mechanical principle. Mass testing, aggressive contact tracing, and enforced isolation act as the pre-hospital triage.
Nations that rapidly activated these measures early in the pandemic, like Taiwan, South Korea, Germany, Israel, they created a public health buffer that diluted the influx of patients.
They effectively converted a catastrophic biological MCE into a prolonged, manageable MCI.
Their hospitals were severely stressed, but their fundamental operational capacity was not destroyed.
Conversely, a hesitant or delayed public health response completely removes that buffer.
The incoming wave of critically ill patients crashes directly into the hospital doors without any mitigation.
This is the exact mechanism of failure we witnessed in Wuhan, in northern Italy, and eventually in New York City.
The failure of the pre-hospital public health buffer translated directly into an unmitigated intensive care disaster.
So whether your system is facing a month of intermittent rocket attacks or 2 months of a respiratory virus, the operational focus of the hospital command structure must expand to encompass the survival of the staff itself.
Because in an acute event, adrenaline carries the team through the first 12 hours.
Right. But in an ongoing MCE, human capital becomes your most vital and most vulnerable resource.
You cannot run your trauma attendings, your critical care nurses, and your respiratory therapists on back-to-back 24-hour shifts for a month.
The burnout becomes a physiological hazard to patient safety.
The text places massive emphasis on enforcing sustainable shift schedules, mandatory rest periods, and psychological support.
The historical examples of staff support the authors provide are a masterclass in pragmatic empathy.
Okay, tell me about that.
Well, during the 2006 Lebanon War, the administration at the Rebecca Zib Hospital in northern Israel recognized a critical point of failure. Their medical staff could not focus on operating on casualties if they were paralyzed by fear for their own children's safety during rocket sirens.
Right.
So the hospital established a nursery school and kindergarten in the fortified underground basement of the facility.
That's a brilliant logistical solution to a psychological problem. By providing a safe, centralized location for their families, the hospital ensured the clinical staff could remain at the bedside.
They also discuss the profound psychological toll of the Second Intifada in Jerusalem between 2000 and 2005. Hospitals were routinely receiving MCI waves from suicide bombings in buses and cafes.
The moral injuries sustained by surgeons treating pediatric blast injuries week after week, I mean, it's cumulative and devastating.
The Israeli hospitals recognized this and instituted mandatory, structured debriefing sessions after every incident, utilizing trained psychologists.
They treated the psychological trauma of the staff with the exact same urgency as the physical trauma of the patients.
We saw the exact same need during the COVID-19 pandemic.
The psychological logistics of managing a team through a prolonged crisis, dealing with severe burnout, PTSD, the moral injury of expectant care, and the terror of bringing an infection home to their families. It is as critical to the surgeon in charge as managing the ventilator supply.
If the team breaks, the hospital breaks.
So, we've covered the entire spectrum from the first hour of an acute event
Yeah.
to the prolonged survival of an ongoing crisis. Let's ground this by addressing a specific logistical hurdle that often arises in these scenarios.
Sounds good.
We like to run a simulated Q&A here, pulling a scenario directly from the text data to apply to your real-world practice.
Right.
So picture this. You are the designated surgeon in charge. A massive coordinated terrorist attack has just occurred downtown. You have 50 patients inbound. You need to clear the ED, halt the ORs, and coordinate with the incident command center. But there's a problem. Your cell phone has no signal. The hospital's wireless communication network is lagging. How do you physically maintain control of patient flow across a sprawling, multi-building hospital campus when digital communications go down?
Well, it's the most critical vulnerability in modern hospital logistics. We are entirely dependent on digital infrastructure.
Yeah.
But the text explicitly warns that in the event of a terrorist bombing, cellular networks are frequently shut down intentionally by law enforcement to prevent the remote detonation of secondary explosive devices.
And even if the police don't initiate a blackout, the networks instantly collapse under the sheer weight of civilian traffic.
Exactly. Thousands of people in the immediate area simultaneously pick up their phones to check on their families or stream video. The bandwidth evaporates.
You cannot call the blood bank. You cannot text the ICU charge nurse to confirm bed availability. Your Vocera badges drop off the network.
Drawing from decades of operational experience, the authors state that the only reliable method of communication in the chaotic first hour of an MCE is a complete reversion to analog systems.
You abandon the digital network entirely.
Entirely. You utilize intra-hospital runners. You literally assign medical students, residents, or administrative staff to physically sprint between the ED resuscitation bays, the operating rooms, and the blood bank with pieces of paper.
To make this analog system function, the text strongly advocates for a specific leadership pairing.
Right. The surgeon in charge cannot be the one writing notes and looking for a runner.
No. The hospital must assign a senior administrative officer to stand physically shoulder to shoulder with the surgeon in charge.
This pairing is the engine of the triage cascade. The surgeon in charge makes the rapid clinical decision. This patient requires immediate damage control laparotomy assigned to OR3.
And the administrator standing next to them immediately operationalizes that decision.
They hand the paper to the runner, they dispatch security to clear the elevator, they relay the blood requirements.
This physical pairing frees the surgeon in charge to keep their eyes entirely on the incoming wave of physiology.
Exactly.
So what does this all mean for you, the clinician preparing for your next shift? Let's recap the critical mechanical takeaways from Schechter and Hirschberg's text.
First, you must intimately understand your facility's surge capacity. The 1 patient per 100 beds per hour metric is the mathematical pivot point between a tough shift and a system collapse.
Know your bottlenecks, your CT scanner, your blood bank, your physical LR space.
Second, understand the triage cascade and the fundamental loss of clinical autonomy. When the surge capacity is breached, the trauma team leader must yield to the surgeon in charge.
The priority shifts from optimizing care for the individual to maximizing survival for the population.
Third, you must be prepared to strip your care down to phase 1 essentials. You abandon the pan scan. You wait on stable peritonitis. You establish strict one-way traffic out of the emergency department.
Fourth, when the volume is insurmountable, the hospital must activate HEICS and focus on failing well.
You protect your traumatological core with staged triage, and you accept the devastating moral weight of expectant care for patients with massive physiological deficits.
And finally, recognize that if the mass casualty event becomes ongoing, whether from prolonged conflict or a biological pathogen, The survival of your institution depends entirely on aggressive public health buffers and the relentless protection of your staff's physical and psychological well-being.
As an advanced trauma provider, your most vital application for future practice isn't practicing chest tubes, it's mental modeling.
You have to mentally rehearse this shift from the fierce, singular advocate for the patient in front of you to the cold, utilitarian manager of finite resources.
You need to integrate the exact verbiage you will use to deny an OR to a colleague into your mind today, long before the disaster strikes and the bays fill with smoke and noise.
When the surge hits, your muscle memory must be organizational, not just procedural.
The decisions you make in the first 15 minutes will dictate the survival rate of the next 100 patients.
Which leaves us with a final provocative thought to carry into your next rotation. We discussed how quickly cellular and wireless communications fail in an MCE, forcing a desperate reversion to paper runners and whiteboards.
Right.
But think about the profound evolution of medical infrastructure since this text was authored. U.S. Level 1 trauma centers have become completely, inextricably reliant on centralized, highly specialized, cloud-based electronic medical records.
The EMR dictates your blood typing, your medication barcode scanning, your imaging processing, and your patient tracking.
The digital tether is no longer just a convenience. It is the central nervous system of the hospital.
So the question you need to ask yourself as you walk into the bay tomorrow is this.
If a massive kinetic event occurs, and the cellular grids collapse, and a cyber attack or power infrastructure failure simultaneously takes your EMR completely offline, how vulnerable is your specific hospital surge capacity?
If the CT scanner is a brick, the automated medication dispensers are locked, and the screens go completely dark just as 50 casualties arrive at the dock.
Are you and your team truly prepared to navigate the muddy waters? Thanks for taking the deep dive with us. Stay curious, stay prepared, and we'll see you next time.